Welcome, guests. I'm Tarina Scott, president of the Theta Mu Omega chapter of Alpha Kappa Alpha Sorority Incorporated. And on behalf of our chapter, I'm delighted to welcome you to tonight's Empower Your Heart Cardiovascular Health Series, presented by our world-winning Health Committee. We're honored to have Dr. Shanice Gilliard with us to share valuable insights on keeping your heart healthy, because your heart works hard for you every day and it deserves a little extra love, and not just the romantic kind. Tonight promises to both be informative, inspiring, with practical tips to help keep your heart strong, steady, and stress-free, even when life or people try to raise your blood pressure. So settle in, grab your water or green tea, and get ready to empower your heart and show it the care it deserves.
Okay. Good evening, everyone, and thank you so much for joining us. My name is Katina Jones, and I'm a proud member of the Theta Mu Omega chapter of Alpha Kappa Alpha Sorority Incorporated. Our health committee is passionate about creating spaces like this, where we can have open and honest conversations about the health and wellness of Black women in our community. We know that Black women face unique health challenges when it comes to healthcare, whether it's access, treatment, or simply being heard and understood. That's why these kinds of discussions are so important. They give us the chance to learn from trusted experts, share experiences, and remind one another that our health truly matters. Our goal tonight is to educate, empower, and encourage each other to take charge of our well being, because when Black women thrive, our families and communities thrive too. And now it's my pleasure to turn things over to our chapter vice president, Jasmia Newman, to introduce our speaker for the evening.
Good evening. It is my honor to introduce tonight's distinguished speaker, Dr. Shanice Gilliard, an accomplished interventional radiology physician at UCLA, whose career beautifully bridges excellence in medicine, research, and community service. A proud native of Raleigh, North Carolina, Dr. Gilliard has journeyed from the East Coast to now joyfully call Los Angeles, California, her home. Her academic and professional achievements reflect her unwavering commitment to service, learning, and global connection. As a Moorhead Kane Scholar at the University of North Carolina at Chapel Hill, Dr. Gilliard earned her Bachelor of Science in Public Health with a minor in chemistry, graduating with distinction. Her intellectual curiosity extended far beyond the classroom. She studied Mandarin Chinese, French, and medical Spanish, and her global studies took her to Rwanda, Malawi, South Africa, and Kenya, where she taught English and science to students and served in local hospitals. Her passion for medicine and cultural exchange continued through her time at Case Western Reserve University School of Medicine, where she was awarded the Satcher Permis Scholarship. She distinguished herself further through international research at Zhejiang University School of Medicine in Hangzhou, China, and later as a Sarnoff Cardiovascular Medicine Fellow at UT Southwestern. Dr. Gilliard's postgraduate training at Harvard, Emory, and UCLA further solidified her expertise and leadership in the medical field. Today, she continues to merge her clinical excellence with service, co-leading the Community Service Division of the Charles R. Drew Medical Society. Alongside with Dr. Jessie Stewart, she leads semi-annual surgical trainings, trips to Nairobi, Kenya, empowering residents in minimally invasive surgery. Dr. Gilliard's story is one of purpose, perseverance, and passion, a shining example of what it means to serve both locally and globally. Please join me in welcoming Dr. Shanice Gilliard.
Hi, everyone. Thank you so much for all the love. I am so honored to be here and excited to talk to everyone. So without further ado, I'll get into our presentation because I know it's a little bit late, and I'm just really appreciative that everyone's here with us tonight. Okay, so I'm going to share my screen and then we'll get started. One moment. Okay, so for this presentation, I'm going to ask that everyone joins and basically, let's see, sorry, just a moment. All right, can everyone see my screen now? Great. All right, so we're going to have some audience participation in this. So we're going to have some links in the chat, and I would love for everyone to participate just to make it more engaging and fun. So again, thank you everyone. Thank you all for coming. My name is Shanice Gilliard. I'm an assistant professor of interventional radiology at UCLA, and my job sort of bridges the gap between diagnostic imaging procedures, and I also do a lot of work looking at CAT scans, et cetera, and diagnosing coronary artery disease. So today we're going to talk about cardiovascular health. So it's going to be cholesterol, hypertension, diabetes, oh my, how silent illnesses can cause cardiovascular health problems. And I think this is really pertinent because they're silent, so we don't often talk about them. So I'm going to give you just a little bit about me, although that very embellished introduction did a really great job. So I'm a Tar Heel from the state of North Carolina. I went to UNC Chapel Hill. Then after Case Western, I went and had a great time. So this is me graduating with a baby face and still looking a little tired. And then I brought this picture in because this is my Uncle James, who I unfortunately lost as a part of a complication of cardiovascular illness. And so I just wanted to include him in this presentation and just honor him because I was at least very thankful that he was able to walk with me at graduation. And then this is a trip from our most recent trip to Kenya. So this is myself and then Dr. Stewart and a team of our residents and our technologists who come every year with us to Nairobi. And it's great fun, and then we learn a lot, and the residents as well that are actually training in Kenya also learn from us. So it's a wonderful experience, and we go every year. So I'm going to ask everyone to get off their phones, and we also have a link, I think, that we just dropped in the chat to go to something called polleverywhere.com, and I want everyone to try to participate because we're going to have questions, and I want to show the audience participation. So our first question is up, and I would love for everyone, let's just make sure the poll is active. It is, to participate if you can. And the first question is, who knows someone with high cholesterol? And we're going to start showing our survey results in just a moment. Okay, so we're going to share this screen so everyone can see. So as results are coming in, we can kind of see that we're all, I think, overwhelmingly Black women, but some Black men might be in the room, but Black folks in this space. And so many of us have either high cholesterol ourselves, we have someone we're blood related to by 1 degree that has, like, over half of us in this audience have a parent with high cholesterol. So that means that if you're in a room, you look left and you look right, at least one of the people you know has a parent that has high cholesterol. Over half of us do. And that might have some impact on our future. And so it's really important that we know these things. So I'm really proud of you all for just even knowing that, because that's one of the first steps to being able to take control of your health and your outcomes. So I'm just going to toggle back to the rest of our presentation. And we'll continue. So thank you all for participating in that. Okay, so the reason we are here today is for some learning objectives. So the first thing we're going to talk about is, number one, what are our silent killers? We're going to talk about symptoms and causes, risk factors. We're also going to look into diagnosis and treatment. And I really want to get into some of the more granular details of this, because I don't think that we as physicians do a good job of explaining why we're putting someone on something. So a lot of times my patients look at me and go, well, doc, I'm not taking care of that. I'm not taking that medicine because it made me feel bad. And I felt fine before I started taking it, but your blood pressure was like 200 before you started taking the medicine. And now you might be feeling bad because your body's adjusting to the medication. So just understanding that, but really importantly, prevention, because all of us, just by being Black Americans in this country, we all have chances where we need prevention. And so we need to empower ourselves to know, okay, if I do have this diagnosis or if I'm at risk, what can I do to take care of myself better? So what are the silent cardiac killers? If anyone wants to, I already put them in my presentation. If you want to chime in, you're more than welcome to. But the first thing I always tell folks is high cholesterol. And it's silent until it's not. So all of these things are really silent until one day they become a problem. And that's why we have to test for them. The next one is high blood pressure. So a lot of people walk around with high blood pressure and don't know it, which makes it quote unquote silent until again, it's not, or it may become a problem later. The other silent quote unquote killer is, I saw someone in the chat put high blood pressure. Thank you. Diabetes. So a lot of folks have diabetes. A lot of folks don't know that they have diabetes. And that time period between having diabetes and having long time having high blood sugar, and then actually getting a diagnosis can really cause a lot of problems for people, including other things that we're going to get into. So we're going to demystify cholesterol first and foremost, good or bad. So cholesterol is a big word for basically complex fat. If you look in medical journals, or if you go into something called PubMed, you'll see that a lot of research scholars, myself included, describe all of these different lipoproteins. So these are basically fat that are attached to a protein. Now, why is this important? We're going to talk about in just a second, but your doctor should test you at least once for your cholesterol blood levels by doing a fasting blood test. Sometimes if you just ate a hamburger and fries right before you go to the doctor and you get your blood test, your numbers might be a little bit confusing. So we always like a fasting blood test, and it helps with the sugar, which we'll get into a little bit later. So does anyone in the audience have an idea about the difference between HDL, LDL, TGs, and all these other kind of acronyms that doctors like to throw around and then don't explain? You can feel free to unmute yourself. Good cholesterol versus bad. Yes. An idea. Yes. I'm seeing in the chat. So LDL is bad. Yes. Very good. Okay. Well, yes, you're right. LDL is bad. So LDL actually stands for low density lipoprotein. So the lipid plus the protein, and it's low density. It's just an acronym. And yes, you should definitely ask by the time you're 30. You should absolutely get one. Honestly, for Black patients, oh, sorry, someone just in the chat asked, is there a certain age you should ask for a cholesterol test? Honestly, I'm starting to see high cholesterol in younger people. So as part of your primary care visit, I think a lot of doctors have started testing at age 25, but everyone recommends, honestly, the European guidelines tend to recommend 30, absolutely, but 25 for a baseline just to understand, especially if you have a family history, is going to be really important. So the low density lipoprotein, or our LDL, is considered the bad cholesterol. It's gotten a bad reputation for a very good reason. So having high LDL levels increases your risk of stroke, it increases the risk of heart disease, and increases the risk of heart attack. So all of the guidelines across the world recommend having lower LDL. Someone in the chat, Jasmine, thank you so much, just asked a question. If the HDL are high, are you in good standing? That's a little bit complicated, but I appreciate you doing that because it cues up our next topic, which is that HDL is associated with basically a lower risk of having atherosclerosis or plaque-related heart disease, but it doesn't cause improved cardiovascular risk. And the reason we know that having high HDL, even it's associated, but it doesn't cause it, is because in the mid 2010s, or even around then, a lot of drug companies put a lot of money into trying to make a drug that increased people's HDL without touching any of the other cholesterols. And they pumped millions and millions of dollars into these projects, and every single study showed that there was no difference in just increasing the HDL. So the HDL does help a little bit with eating up the cholesterol in your body. So it kind of will bring it from the liver to your colon to get eliminated. But we don't necessarily think that having high HDL itself causes you to have better cholesterol. And then Megan put a point in that pediatricians are now routinely testing. And that's true, because what we've learned is that a lot of genetic syndromes can present in childhood. So most pediatricians will do at least one baseline test so that they know if they need to, like how closely basically they need to monitor cholesterol in children. There's another lipid protein or lipoprotein that you might hear your doctor talk about called triglycerides. And triglycerides actually are just a different lipoprotein, but they're derived from fats. So anytime we eat like something super fatty, or like they'll say you have these fatty chain triglycerides, or any of these meals that have a lot of fat in them, that can increase our triglyceride level. And why is that important? Is just because all of these put together, the LDL plus the triglycerides can add up to your total cholesterol, and that could cause you to have some challenges if it's too high. So I'm going to go to the next slide, sorry. So which levels are bad? So I've made it real simple for myself because I'm a visual learner as someone who studied radiology. And so heart healthy basically this is a graphic from the American Heart Association. And when your total cholesterol, which is your HDL plus triglycerides and all the other ones, is under 200, we're happy, especially if your LDL cholesterol is under 100. If your HDL cholesterol is 60 and higher, that's associated with better outcomes. But really, once you start getting into this kind of range, especially as women, our range is a little bit different for our HDL. We need higher HDL than males to have equal risk, okay? Then we are looking at being at risk to be in the danger category. And the reason we have a really sad face by the danger category is that once the cholesterol is at 240 and the LDL, or the really bad one, is at 160 and higher, we're at risk for very, very dangerous outcomes, especially when it comes to plaque building up and blocking up our blood vessels, which is honestly what cholesterol just loves to do. It's sticky. And if you've ever made anything with butter, once your pan cools off, it's kind of like that. It's like extra fat that's just sticking around, and it's just sticky, and it's sometimes really hard to get off. And unfortunately, that can happen inside of our bodies. So why does this matter? Again, it's been reported, and this is not like one report. We're talking, it has been reproduced in multiple countries in multiple spaces, that individuals with elevated total cholesterol, so that 200 and up, not the extremely bad one. I'm going back to the slide just so we can see it. This one actually have 2 times the risk of having cardiovascular disease or coronary heart disease than those who have optimal levels. So once the levels actually get into that mid-range, the risk doubles for something bad happening. And now we're going to get into what exactly are those bad things. Okay, how do you lower your LDL when you have food allergies? Okay, I'm going to answer that in a little bit. Thank you, Jordan. Okay, so first off, we'll talk about the consequences of high cholesterol. So like I said, plaque buildup happens, and that's just called atherosclerosis. So one of my jobs as an interventional radiologist who really works on opening up blood vessels in people's bodies. I specialize in opening up blood vessels in the legs, which we're going to talk about at our next session. But this kind of happens. So when patients have very, very high cholesterol that's not controlled well, it can really build up, cause plaque or to build up into the blood vessel wall. And then that becomes sticky, and the plaque itself actually, what'd you say? The plaque itself has properties that make your blood vessels, or your the platelets in your blood, clot. So it causes all these sticky factors, and everything becomes sticky on the inside, and then that increases the risk for clot. It also can increase your risk for heart attacks, because that makes sense, right? So you've got all this sticky stuff going into the blood vessels. Your heart is a muscle. It needs blood vessels to eat and to feed itself. And then once those blood vessels become completely blocked up, that causes a heart attack. Another thing that people don't actually hear about a lot is it can actually cause liver disease. And what I've seen is actually very like scientifically interesting that in African Americans, the way we process cholesterol may not actually increase our risk for liver disease, but overall, having elevated cholesterol over time can increase your risk for liver disease. And so what we call this is non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis. And I have seen patients that have had such bad liver disease that they ended up needing liver transplants. And once you're at this point, it can be very dangerous to have a liver transplant, because all the blood vessels in the body have started off with a sticky plaque and then progressed to this level. The other thing that is what I really treat and specialize in is aortic disease and peripheral artery disease. So by show of hands, has anyone been up at 2 o'clock in the morning when the TV's gone off? I'm dating myself now, and heard, do you have restless legs? Do your legs go numb? Are they tingling? You might have PAD. Like, has everyone heard that term before? I remember, yeah, okay, I see some hands raised. I remember when I was like really little and the TV went off and I couldn't sleep, and I was like, what is this? This sounds terrible. And so PAD is basically the same thing that's happening in the heart with a heart attack. It's happening in the legs, because our legs are screaming for oxygen and they're screaming for blood. So I tell patients all the time, if you're having this PAD or this leg cramping and this pain, that is our warning sign that something else is going on in your heart, because it's the same process that's happening. All the blood vessels are the same, basically distributed. And so if there's a problem with blood vessels somewhere in one place, there's a problem with blood vessels in another place. And so we're going to talk a little bit more about aortic disease and cardiac disease next time, but I wanted to talk about the risk factors in this session. Okay. Sorry, I saw one question in the chat. Thank you. I'm glad this makes sense. That is it considered high if the HDL is higher than usual, like total is over 200? So if the total is over 200, that's still considered high. If the HDL is the higher factor, that may not be considered high, but we would need a breakdown of all the cholesterol. So, and then sometimes you might need a lipid specialist to kind of look at all the numbers and go into more genetic factors to look into that in a deeper level. So it's a hard question to answer without more information. Okay, so we're gonna go to our next slide. And my next slide is basically, we're putting LDL in jail because we don't want that. And we also need to advocate for our sisters, which we are doing beautifully on this forum. So one thing I want everyone to remember is women are less likely than men to be prescribed or offered lipid lowering therapy, even if they qualify. So if you're a woman and you have slightly higher cholesterol, statistically, you're less likely to actually get the medications to prescribed. And it is like shown in the literature. And as I was preparing this talk, I was kind of upset about it. I have no idea why. Unfortunately, there's still a lot of biases in medicine where women just are not prescribed at the same level as men. A lot of our studies, again, have been done in men. Lately, okay, I'll say 10 years ago, science was looking to be more have more parity. So have more women in studies, more minorities in studies. Currently, that has the focus has changed from the National Institutes of Health. So what we're studying is under more scrutiny. So having that parity that we were really fighting for 10 years ago is not quite the same, which is a little stressful and a little upsetting. So you might have heard about something called statins, which is a big umbrella for these medications. A lot of them end in or. So Lipitor, Crestor, all of these different things. These have one specific mechanism. They're all basically essentially the same, except for like very minor details. What they do is they inhibit cholesterol building blocks to reduce your overall cholesterol. So cholesterol is a big giant molecule, and it basically stops the body from building it up so that it overall basically helps reduce your cholesterol. Those aren't the only medications to help reduce your lipids. There's some newer ones that called PCSK9 inhibitors. I actually worked in the lab that discovered this molecule, and it helps the liver actually eat up the LDL. So remember how I said when you have really high cholesterol, it can affect your liver? That's because our livers actually process the cholesterol by eating it. And this particular molecule, when people have problems with this molecule, their liver can't process their cholesterol properly. So it makes their cholesterol very high. And so that's why when sometimes people have medications that don't work, they might need more work to understand what's really going on. There's another medication called ezetimibe. I don't love prescribing this medication because it blocks cholesterol from being absorbed. And you can imagine how that might go if you're eating something and you can't absorb any of the fat that you're eating. It'll cause a very, very, very upset stomach for a lot of people. So patients will try this drug and most people say, I just can't do it, doc. I hate it. So that's why we kind of go into these different categories. The good news is there are a lot of molecules and drugs that are being made to target different parts of cholesterol as we build more knowledge about it. So if something's not working, the best way to advocate for yourself is to tell your doctor, like, this is not working. Is there more information we can get? Especially if you've like, my grandma has high cholesterol, my daddy has high cholesterol, I have high cholesterol, and I am not getting I feel like I'm taking my statin every day and my cholesterol is still high. That means more work needs to be done. All right, so we're going to go back to our poll. Are there holistic treatments? I don't want to take a bunch of medications. Okay, I'm gonna hold on to that because I think that I have some answers in my slides in just a little bit, but yes, so just one moment. Okay, so we're going to go to our next question. And so kind of what would you describe your experience with the doctor? And we're getting some things surprisingly helpful. That's good. Inconsistent, which is unfortunate, but people have different practice patterns. Sometimes good, dismissive, impactful, quick. Yes, that can happen. And quick, okay. And I hate that it's dismissive, but inconsistent is I'm getting a lot of that. I see excellent, so that's nice. Okay, so the reason I kind of had us do this word cloud exercise is because Monet actually just asked a really interesting question about like holistic care and learning about, is there anything else I can do? And sometimes the answer is yes, and sometimes the answer is no. And the hard thing is it depends. And so the most important thing you can do, we're going to talk about this at the end, is assembling the team to take care of you, because it can really make a difference in your care and your experience. I'm going to switch over and I'm going to go back to our. So what can we do? Monet, that was a perfect segue. So diet and cholesterol. Your diet directly impacts your cholesterol. We know this, and there are going to be some people for whom diet modifications don't work. Those are folks that are, and that's the reason we test children, because some children have like a genetic condition that will always make their body make more cholesterol or not process it appropriately, no matter how strict they are with their diet. So one of the questions I always ask is a keto diet, does it work? And so an extreme keto diet actually can raise your cholesterol because you are basically only doing fats and protein. And so if your keto diet lends more fats than protein, the balance can actually increase your cholesterol. But the one thing we know, Mediterranean diet actually works. So there are so many studies that show this across, like in Europe. I'm one of those folks that I like looking at the European studies as well as the US studies and kind of comparing and contrasting the guidelines. And so Mediterranean diet plus exercise actually has been proven to decrease your waist circumference, increase your HDL, and decrease your LDL and triglycerides. And this has been proven in studies where they gave patients one guideline to follow and then said another one. And they said, okay, this group will take the Mediterranean diet plus like an exercise program, and this group will do like their regular diet or a different modification. Like the American Heart Association had a diet recommendation, and the Mediterranean diet actually outperformed the American Heart Association's recommended diet. And so we know that for a fact. The biggest takeaway is less saturated fat, more olive oil. It sounds kind of crazy, but it actually does work. I got another question about an adequate time frame to determine if something is not working. Okay, it depends on the medication. So for diabetes medications, it's about 3 months. They'll want to, again, when they take labs, they're going to look at a 3-month snapshot of your blood sugar. For cholesterol, it's about 2 to 3 months. So usually when folks have elevated cholesterol, they need to see their doctors at least after starting 3 months after starting the medication, just to make sure that things are moving in the right direction. Okay, I think I already gave us the answer to our next question, but I'm going to ask one of my assistants to see, was that the keto question? I think it was the keto question. I gave the answer. Oh, it was, okay, great. All right, we're going to move on to another topic. So we're going to talk about something else. So I want everyone to answer our next poll question. And what is a blood pressure diet? Okay, this is an amazing question. All right. We have low carb, low fat, I don't know, dash. All right, I'm so excited. Has everyone answered all the poll questions? Think we've got a quorum? Okay, great. So even though usually majority rules, this time, the folks that said the DASH diet were correct. So we're going to talk about that. So hypertension is the pressure, and normal blood pressure is 120 over 80 millimeters of mercury. To diagnose hypertension, though, you need more than one reading. Okay, so if you go to the doctor, this thing right here that I'm wearing tends to drive people's blood pressure up. I don't know, just seeing a doctor is scary. I honestly don't even like going to the doctor myself. And so we need to know our ranges. So this is another scary looking table. Normal is like less than 100, the top number being systolic, the bottom number being diastolic. And once it's elevated, like when you're in like the 125, 126 range is elevated, but that doesn't mean it needs to be treated. Once we start getting to the definition of hypertension, we're at 130 for that top number and over 80. Now, the question about that is, where do we start treating? Most practices, like the American Heart Association, recommends treating at the 140 range, though some studies show that if you consistently live in like the 130s, getting it down lower is actually better for your overall risk of things. The severe hypertension, if you're coming in to me and your blood pressure is 180, and that does happen in my health fair sometimes, folks go, oh, someone told me I had high blood pressure, and their top number is like 200, and then my eyes get wide, They're like, everyone's eyes get wide. I'm starting to stress. We're in a park here. I'm like I want to call EMS, but I don't know. And I do send them to the hospital because this is a hypertensive emergency, and hypertensive emergency can become a really bad emergency, including having stroke, like having an aortic dissection, meaning the biggest blood vessel in the body can tear, and other things. So if someone has really high blood pressure and blurry vision, chest pain, a really bad headache, that is an emergency. Go to the hospital with all the lights on. Okay. And if you have a history of hypertension or high blood pressure, I like to recommend that you keep a blood pressure cuff at home. That way that we don't have the bias of the white coat. Thank you, Ms. Scott. The white coat hypertension telling your doctor that your blood pressure is higher than it was, or maybe you were running out of the house, like running late to the appointment, just made it on time. Now your blood pressure is really high. So that way you can keep readings and kind of check it at home when you're in a more relaxed environment to give your doctor the best information possible. So let's not be salty here. Salt. So what causes hypertension? Genetics. We know genetics cause this. White coat hypertension is real. Diet has a big effect. And I put racism in bold because it's very interesting. A lot of studies are starting to tell us that being in a country that has very racist policies, very racist experiences, increases something called cortisol, which can cause our blood pressure to go up. So that is a real thing, and I can't discount that. And, other than saying we should all just get on a plane and move to Fiji or somewhere else, I don't really know how to fix that. I'm totally in favor of that, by the way. But the prevalence is very high in America. Up to 47% of American adults have elevated blood pressure. Do they have blood pressure that's so high it's necessary to treat? Maybe not. But almost like half of the adults in America are in an elevated range where they're at increased risk for things. So again, what are some risk factors for high blood pressure? We have age, obesity. These are like kind of things that people just always throw out, and they're not very specific, but an unhealthy diet can definitely do it. Smoking, diabetes, and family history genetics. So those are some of the big things. But what are the consequences of having high blood pressure? You might not feel having elevated blood pressure, but it can feel you. So kidney disease, having stroke, dementia, heart disease, heart failure, and even eye problems. Those are all things that can happen when blood pressure is really high. So did you know that high blood pressure is the leading cause of spontaneous hemorrhagic stroke? And so the reason I bring this up is that when I lived in Atlanta, Georgia, one of the things that I was shocked by, and I do mean shocked, was how many people that were too close to my age for comfort were coming in with strokes. I worked at a stroke center at Grady Memorial Hospital, and it was not uncommon to have a 47-year-old come in with a brain hemorrhage. And then you ask their spouse or their family, do they have high blood pressure? Yes, they said they had something like that, but they said, I feel okay and I don't not to worry about it. And like, this has happened to, the spouse of a very close friend of mine, where their spouse wasn't taking their medicine, and one day had a massive stroke at the age of 47. So how do we treat high blood pressure? It sounds really redundant, but it's diet, exercise, and sometimes medication, depending on if the first two things don't work. Just want to keep an eye on the chat. Oh, dementia. Yes, someone just meant. Okay, so I'm just going to ask a couple of questions. Megan said, is it true that to get an accurate blood pressure reading, you have to be sitting with feet on the floor, quiet? Yes, because when you're running in, your body will squeeze your arteries so that it can give you the blood to your brain that you need when you're running. So when you're running, your blood pressure is going to be a little bit higher than when you're sitting and relaxed. And then dementia, yes, high blood pressure can cause dementia because people with long-standing high blood pressure that's not treated can have micro strokes, and that can cause something called vascular dementia over time. So treatment, like I said, is diet, exercise, and medication. So I already answered our question, what's a blood pressure diet? So I'm going to skip this next one then, but it's DASH. So has everyone seen this in the grocery store? I actually went to the grocery store today and was looking for some seasonings from something else, but I was like, oh, they still have the DASH. This actually stands for dietary approach to stop hypertension. That's literally what it stands for. And so these are blends of seasonings that don't have salt, but still have flavor. Is it the same? No, I recognize that. I respect that, but it is still a lot better. But salt reduction can really reduce your blood pressure. So reducing your salt intake can reduce that top number by 8 millimeters of mercury. So it can actually bring you down one category of range almost. And this is proven again by multiple studies. So if you have a history of high blood pressure, yeah, there are a lot of blends of salt-free seasoning. Limit your salt intake to 2 grams a day if you have a history of high blood pressure. So I did this exercise. I was like, okay, what does that actually look like? So if you go to In-N-Out, this is the In-N-Out menu, the sodium, so this is already 1600 milligrams, which is 1.6 grams. And if you have a double with onion and French fries, you've already actually gotten 2 grams of salt. Not my double and fries. Yes, your double and fries will get you. No more salt for the rest of the day. Don't even no salt. No, don't even put any salt in your scrambled eggs. We're done for the day. Like we are done. We've reached our limit already. And the problem is that salt is really sneaky. It's so sneaky because it hides in a lot of things. So I was like, oh, but what if I go to Chick-fil-A and I'm healthy because I'm going to God's restaurant instead of going to the heathen restaurant. And so I am like, okay, I'm gonna get some minis. Wait a minute, is that 2.6 grams of sodium? We're already there. And then let me be healthy and get the egg white grill. That's already a gram of sodium. So if you get an egg white grill and some hash browns, you're already there. And even if you take your blood pressure pill, you're gonna be mad at the doctor that it didn't work. But it might be if you went to Chick-fil-A that morning, you already had 3 grams of sodium and then you haven't even had lunch yet. And someone said, yeah, Megan said, I reverse high blood pressure and cholesterol with exercise and intermittent fasting and eating half the food. Yeah. So, and then I'm sure when you're really thoughtful about it, you're probably also really being careful about what food you're eating and reading those labels. Oh, yes, this Eggo waffles. Oh, someone said their daughter used to eat a lot of Eggo waffles and was appalled by the sodium. And it was a lot of sodium, but oh, I loved my Eggo waffles. Spike veggie salt, that's actually okay because it's true sodium. It just has like kind of a salty taste. Okay, so I always say read the labels because gave yourself a high five, like, yeah, I have high blood pressure, I went to the gym today, I got a great workout in, I'm gonna get some Propel to reward myself, and that's healthy. Yes and no, because there's so much salt in these rehydration formulas. So if you have a history of high blood pressure, your body might not be able to handle the extra salt load. Whereas, if you don't have high blood pressure, it's you may be able to get away with Propel. But yes, avoiding processed foods. Okay, I'm probably going to skip to our next couple questions. Let's see. Yes. Oh, okay. So I'm going to show our responses here. And true or false, vaping does not affect blood pressure. So a lot of us stopped smoking, the millennials stopped smoking, and then Gen Z was like, we're gonna pick up our vapes because they smell better than cigarettes. So are we going to have a blood pressure crisis with our Gen Z kids soon? Okay, vaping is worse. Okay, that is indeed correct. I'm gonna bring us back here. And So vaping is actually worse. So smoking and vaping can raise your blood pressure by about 10 points. So again, if you're, or you or someone you love is fighting for like having high blood pressure problems, they're trying to drink their water, going to the gym and taking their blood pressure medicines, but they're smoking and vaping, they're kind of undoing at least 10 points of the blood pressure medicine's job by doing that. So smoking is really, really bad for you. Ooh, okay. Electrolyte replacement for perimenopause when you have high blood pressure. Ooh, that's tricky. That actually, if that's a consideration, it might be worthwhile getting either a hypertensive specialist or an endocrinologist who can help with the hormonal balance and kind of doing like that kind of same thing, because that can be really specific and really tricky. So having both of those specialists could help figure out what the right balance is for you. Okay, exercise though is really good for blood pressure. So there were some studies that looked at exercise. 30 minutes of exercise 3 times a week can reduce your systolic blood pressure up to 10 millimeters of mercury, so that top number, and the bottom number by 7. But what was interesting is it's not just walking. So when I was, doctors say, oh, diet and exercise, they're never really specific. So in the studies that showed really sustained exercise, it was a little bit of resistance training. So actually building your muscles and helping like kind of with some like slow resistance training, something like Pilates or muscle, if you're going to a gym and you're doing some like gentle weights, that can actually have a really good effect on your overall blood pressure, which we have seen in multiple studies. Okay, but we do need to talk about these medications. So there are multiple categories of medications for blood pressure. We have ACE inhibitors. These are yoga is great too. Yes. And these will be your prils. So lisinopril or canosartan. So these are ACE inhibitors or angiotensin receptor blockers. These are all kind of acronyms, but these basically block the enzyme in your body that tells your body to raise your blood pressure. There's another, and that is usually the first step that primary care doctors do to like work on your blood pressure. The next category is called your diuretics. So there's thiazide diuretics or loop diuretics, like hydrochlorothiazide is something that a lot of people put in. And there's some combination pills that people take. Or furosemide, which is Lasix, exactly. These eliminate water. So you urinate out water to reduce the amount of volume in your body that reduces the pressure on the walls of the blood vessel. The important thing is when you're on these medications or somebody you love is on these medications, you have to check their labs, because when you're peeing this stuff out, the other stuff that comes out is also salt and potassium and other things. So if someone has too much of this medication, basically their electrolytes can be out of whack. There's another medication called amlodipine that is pretty common if you don't have very, very bad blood pressure. Some doctors will prescribe this first. It relaxes the walls of the muscle. So like sometimes our blood vessels are muscles, so they'll squeeze. And it relaxes the walls. Now, the problem is once it relaxes the walls, water can kind of seep out. And so the most common complaint for this one is ankle swelling. The other one, we don't often reach for this, is beta blocker. So you probably heard the term low pressor when your grandma was like, hand me my heart pills. And it's a very old medication. It's very well tolerated. It relaxes the blood vessel walls, and it also slows down the heart. So those are used usually when someone also has heart failure and they need some support in that way. So the one warning I like to tell people is ACE inhibitors can cause something called angioedema. It's not an allergy per se, but you have to say it in the chart. Basically, it can cause some swelling in the mouth and the face. It happens in like 0.2% to 1% of cases, depending on what study you read. It is more common in us, and that's why I put a big warning sign. The biggest warning sign is if it happens, do not try it again. Make sure every single person in your life knows that this happened. And the reason is because Once it happens once, the second time is a lot worse. It's just like having any kind of allergy, like a bee sting or anything along those lines. If you notice any kind of swelling with any medication, just stop it, call your doctor immediately, and then even consider going to the hospital, because if there's any swelling in your face or lips, it can potentially stop your breathing. And I have a very close friend who unfortunately had her father had it marked in her chart and got the wrong medication and had, a very severe outcome. So just remember that. Okay, so for the sake of time, we're going close. I'm going to stop our polls for now, but we're going to talk about diabetes or the sugar. Okay. Prevalence, diabetes is very common. 20 million adults in America meet the criteria for diabetes. Only 20 to 30% are but almost a third of them are undiagnosed at any time. So, I actually, when I was putting this talk together last week, I did my own finger prick just to make sure that I wasn't one of the 30%. So I didn't want to be telling you all things and not actually following my own advice. But normal blood sugars for adults is kind of in this table. So ideally, if you haven't been eating, you need some sugar in your body because your body still needs to run itself. So your blood sugar should never be below 30 or even below 70, because your body should have a process where it makes its own sugar from the stuff your liver basically makes its own sugar. But you don't want it to go too high. So basically, if your body can't stay within this normal range when you haven't eaten anything, then you may be in the category of pre-diabetes. So if you haven't eaten anything and your blood sugar for 8 hours and you wake up and your blood sugar is like 105, we're in a pre-diabetic range. Diabetes is usually defined as once you hit the 126 if you haven't eaten anything. And then also, oh yes, ACE inhibitors can cause a cough. I'm so sorry. There was a comment about that. I'll finish that at the end. So please remind me, Ms. Jones. But yes, diabetes is defined usually after fasting. There's another measurement like postprandial. So after you eat, your body should be able to process whatever sugar you eat. So it should be less than 140, at which you'd be like, oh my goodness, do I have diabetes? But if you ate 2 hours ago, then your body's still processing the sugar and trying to figure out where it should go. And so, no, that's not abnormal. But why do we care? Because the number one cause of death in people that have diabetes is cardiovascular disease. So that's why I brought it into this talk, because it really does have severe consequences for our patients with diabetes. But how does it work? It's blood sugar, it's sugar. How does it cause my heart problems? How does it cause my brain problems? Well, it basically causes blood vessel stiffness. So it makes your blood vessels kind of rock hard. And as that happens, your body starts telling your brain to create increased blood pressure. And the sugar also is a little bit toxic to your body. So it causes inflammation, and over time that can cause heart stiffness and other issues. So I liken this to, I'm again going to date myself, but if you ever had made rock candy out of sugar, so if you ever put a string, I see some people, okay, thank you. I'm glad I'm not the only gray-haired person in the room, where you put some sugar in a cup, like sugar water in a cup, and you put a string in it, and then overnight the crystals grow and you make your own rock candy. I'm from the South, I grew up in that kind of culture. That's what you do. But it's really similar to what happens when there's a whole bunch of sugar floating around the body. It kind of starts sticking to things and crystallizing and causing inflammation. So that's why we care. So the testing it's evolving. The gold standard is going to be the please be fasting blood draw when you go to your doctor. So please don't eat anything the night before, and then they'll draw your blood to kind of do a full diagnosis. The finger prick is not as accurate because we don't know if your body is in the process. If your finger prick says 140 and you just ate some cotton candy, you might not have diabetes, but we don't know. So I like to use these once we have a diagnosis so we can keep patients in our more normal range. We've now evolved. We have this continuous glucose monitoring, and some people love it, some people hate it. I personally, as a physician, I like having more information. So I love it when patients have these, because I don't have to, number one, they don't have to prick their fingers because that kind of hurts. And then number two, there's information that goes on all the time. There's some that are there's some that are FDA approved, and then there's some that are approved that are you can access without a prescription. And so for my patients that are pre-diabetic, sometimes, yeah, there's a lot of the continuous glucose monitoring. Some of the health, like, people like to do it so they'll know like how they can body hack and this stuff that's like kind of not really scientific. But the other thing is, for diabetics, it's great because especially if you're insulin dependent, it helps with safety, because some folks that are taking insulin, their blood sugar drops too low and it gets into a dangerous range, and having continuous glucose monitoring can help alert them before they get really sick. So I really like it. Okay, so insulin resistance, cause and prevention. I'm hoping that my slides kind of come up here. Okay, so one of the things like I wanted to talk about is prevention for diabetes. So we know that inactivity can increase our risk for diabetes and our insulin resistance and our insulin not working as well in our bodies. So I always tell my patients, if you want to lower your blood sugar, actually eat 30 minutes, like eat and then go exercise 30 minutes afterwards. So if you have a big meal, do the turkey trot after Thanksgiving. And what you'll see is that your blood sugar actually does go down, because when you're walking and you're exercising, after your body's processing your sugars, the muscles will actually take up the blood sugar. So they'll actually pull it from the bloodstream and then take them up as like the substrate to reduce the amount of sugar that's just kind of free floating in your body. Yeah, it's nice. I love that little hack. It actually does work. Obesity is one of those things. It's like a big umbrella, and it's really easy for doctors to say, oh, it's because of obesity. But we know that having like more obesity, especially in the midsection, somehow is affiliated with increased inflammation in the whole body. We don't know exactly how, we don't know exactly why, but we know that there's different factors. So having weight loss and some weight monitoring can help with that. Poor nutrition, again, that double also has some carbs in it, and they're so good, especially animal style, but those are extra carbs. So a lower carb, lower sugar diet can help reduce the amount of inflammation and insulin resistance that we develop in our bodies. So the treatment, I know everyone wants to say, how can we avoid drugs? But if you have a diagnosis, listen to your doctor, because it really does help. So metformin is one of our old but good drugs. It's been around for 50 plus years, and it helps your body just improve its sugar uptake and processing. The newer ones that we talk about are like Ozempic, which are the GLP-1 agonists. They basically help shoot insulin out of your pancreas, and they also help make you full because of the way that the hormone works. Like this particular hormone helps make you full, and it also squeezes your insulin out of your pancreas, which is the organ that makes insulin. Now, if your body is not able to make enough of its own insulin, you might have to get supplemental insulin, which basically directly helps your body. It's this insulin is a molecule that tells your body to pull the sugar out of your blood. It basically, that's all it does. It's a key that tells your body, oh, I need to take up the sugar now. But if people don't have enough insulin in their body, or their body is, the lock starts changing, then the insulin, that's called insulin resistance. But these are kind of the bigger categories. There are a lot more, but I don't want to bore everyone with all of those details. Okay, so tonight I'm just going to end by saying, build your med team. So we have a lot of people that can help take care of us, but knowing who to go to is really important. So my team is primary care, cardiology, nutritionists. A lot of us have nutrition. Like a lot of us who are insured, nutrition is actually covered by your insurance. So if you're trying to figure out what kind of diet would be best for me, given what unique concerns I have, getting a formal nutritional content, like a consult, is really helpful. A personal trainer, even if you can't have a personal trainer, finding a gym that is affordable is great. My my gym, I think it's actually pretty reasonably priced. It's called The Camp. It's in Inglewood. They beat me up in the morning. And then I feel a little bit better. I don't look it though at the end. But also an endocrinologist. So people sometimes primary care visits, like when we did our word cloud, was a lot of people feel like things are really quick. And that's true because unfortunately our primary care doctors are under a lot of pressure to have really quick visits just because of the payment model. And so sometimes things do get missed. So the best thing you can do to advocate for yourself is if you're like, okay, I've been on this medication for a while and I'm not seeing changes, or I'm trying XYZ, doc, is it okay if I get a referral to an endocrinologist? Because endocrinologists are really great at treating diabetes. Like that is their thing. They know how to treat it. They understand it in ways that, I don't understand. If we're having really hard time with blood pressure, there's some cardiologists that specialize in blood pressure. They're not super, super specialists, but that's their thing. They love blood pressure. So that helps build your team and then support your primary care doctor in taking care of you in the most holistic way. So with that, I will end and open the floor to questions. Thank you all for your time and participation. Oh, endocrinologist recommendations. Let me see. Off the top of my head, no, but I will give you my email because I am on a group chat with all of the African American doctors in the UCLA system, and I can send a message out to them to see who folks are seeing now and recommend.
Dr. Gilliard, we did have a question earlier about the cough with the ACE inhibitors. You said you were going to
Oh,
come back to
yes.
that.
Thank you so much for reminding me. I really appreciate it. Yes, ACE inhibitors are known to cause a cough. If you're having a cough with ACE inhibitors, you can ask your doctor to switch to a different class of medications. The angiotensin receptor blocker, or the ARBs, those are in the sartan, artan. They have less of the associated cough.
I also see a question earlier that mentioned whether or not Ozempic that it does help with diabetes, but does it help with high blood pressure or hurt high blood pressure?
I haven't seen anything that says it hurts high blood pressure. It makes it worse. Now it is more studies are coming out about this particular drug just because it's becoming more like the use has skyrocketed, especially because we learned that it's a weight loss drug as well. So we'll probably learn more. But what I can tell you is that when diabetes is better controlled and weight is better controlled, there's a associated blood pressure lowering effect. So Ozempic itself won't lower the blood pressure, but having the benefits that it has of controlling blood sugar and controlling the weight or weight loss will associate with having lower blood pressure. But I wouldn't say it causes it. So like,
Gotcha.
yeah, if you're taking like a low blood pressure medicine, the next day you'll see your blood pressure lower. Ozempic, you're not going to see your blood pressure go down the next day.
Got it.
Mm-hmm.
And then there were some questions about suggestions for vitamins, teas, foods, etc., that you might recommend for inflammation.
Okay, so I actually like turmeric tea for inflammation. The thing is, you have to be not so there are a lot of supplements like that you can take. Some of them can be poisonous. Like I've seen like a few cases of turmeric poisoning. Now you have to take a lot. Like, you know what I mean? Like you have to go to the like not even a GNC. Like you have to go to like basically Koreatown and get like turmeric pills. These were like literally people who went to Koreatown, got turmeric pills, and were taking them like 3 times a day. That is way too much for your body to process. But turmeric tea and ginger, I like both of those for like the anti-inflammatory properties. Just like on a personal level, I drink turmeric tea almost once a night or maybe like every other night.
Wonderful. Our president has a question for you.
Oh, yes.
Not a question, just a comment. I didn't realize until I was much older that you have to see more than one doctor.
Yes.
Like you need an internist, a GYN, you need the general practice, an MD. I mean, I think folks need to be more, aware of, what's going on with them and to see a specialist. Because just because your general practitioner, is supposed to know it all, it doesn't mean that they really do and can speak to your, particular need, and especially as a Black woman.
Yes, I always, I mean, even on a personal level, I've had experiences where, I had some very pressing medical concerns, and I was asking for, a physician's consultation and opinion. And this was like during my intern year where I was like a green doctor, but I was still a doctor. And I did not, I didn't get what I needed, and it almost became deadly. So like it can affect all of us. And I think if we just know that there are resources and we can really just advocate for ourselves, that's going to be the best way that we can stay safe, especially now. And then knowing the team. So like I said, if you have like high blood pressure and you're not getting in the range that you want, even though you've tried multiple medications, you can ask for a high blood pressure specialist consult. Like you can just say, look, I need a consult. And it doesn't really offend us when you ask for more care. Like it, if your doctor's offended by that, then it might be time to find another one, just because, you want to be able to get the most comprehensive care that you can possibly get.
And one last thing to that point, I recently changed medical providers, and I have my internal medicine doctor, my general practitioner, and my OBGYN are all Black women, Black females. I also took my son to this particular location, and he was having problems with his feet. And guess who walks in? A Black female podiatrist. And I was just like instantly felt so much different about me and my health concerns, and really feeling like I'm going to be seen and being able, to speak directly to my needs or can relate. So thank
Yeah.
you.
Oh,
Can I ask one more question?
yes.
So how do you go about getting that like specialist, like getting an appointment with the specialist? Like how do you like what do you say?
Okay. So it depends on your insurance, first off. But what I honestly do for myself, this is how I find my doctors. I go onto ZocDoc.com and like plug in my insurance information. ZocDoc may be specific for Blue Cross Blue Shield, but usually I just go into ZocDoc.com and find like the specialist, and I look, and it's kind of nice because the tools, depending on the practice, sometimes folks will like have their availability listed. And that's how I've been able to find my doctors. A lot of times they have the picture. So on the website, they might not say this is a Black woman, but if you're like, you can see the picture, you go, okay, let's see. And that's how I've honestly been able to assemble my healthcare team, by aggressive Googling and aggressive ZocDocking.
I would also suggest that you speak to your friends and family and talk to people that you know, and find recommendations that way too. If you happen to know people that work in the healthcare profession, they can also be a good resource for physicians that you may be looking for as well.
I did not feel nice at the time.
You also can just ask your, I'm sorry, can't you just ask for a referral to see a specialist?
King County Jail for the night work.
Yeah, you absolutely can.
So he's not here in the city of Beer at night.
I believe you can in most cases. I think you mentioned, Dr. Gilliard, before that you should definitely check your insurance first, though, to make sure that that is part of the coverage that you have.
Yes.
Go ahead, Shelley. I see you have a question.
So I was just going to add to that conversation. I would also say don't assume that the referral means that the next doctor takes your insurance, you definitely have to do your own due diligence and make sure that your insurance will cover the next doctor. I've seen this happen multiple times with patients who are referred to a specialist, and they get a different outcome once they go to the doctor.
Mhm. Honestly, sometimes I will call the office like a week before my appointment and just make sure that my insurance works, because paying out of pocket, especially in this economy, is not the move.
What about fibroids? Does fibroids have any impact on your blood pressure? Because I was having challenges with fibroids for years. I'm older now, so I had a hysterectomy. And I used to have problems like being really slow, sluggish, iron. I had a little swelling. And then afterwards, I didn't experience that anymore. And
Okay.
so I was just curious what your thoughts are on that.
So, yes, and so fibroids are associated with a lot of really heavy bleeding, and to the point where a lot of women become anemic, like severely so. And when you're anemic, you can either do one or two things. You can go have low blood pressure because your body is like bleeding really badly. That's an emergency. But sometimes the reverse can happen because you have low blood, and so your blood vessels kind of constrict a little bit to try to increase your blood pressure because you're losing water or volume through bleeding out. And so that is probably definitely why you need an iron. And it can, and also being in pain can increase your blood pressure. So if, fibroids can be excruciatingly painful, especially on a cyclical basis. And so being in pain can actually increase your blood pressure by like 5 to 7 points. And so that's that's kind of the effect.
Mhm.
Yeah.
I noticed at the height of my, dealing with all of that, my blood pressure was the highest it's
Yeah.
ever been. And one time I went and I did a blood pressure reading and then went home. About 10 o'clock that same night, my doctor called me
Wow.
and was like, and they also took my blood when I was out there. They were like, how are you even functioning? They wanted me to come into the doctor's office that evening at 10 o'clock. And my
Wow.
doctor was like, "Are you okay? How do you feel?" And I was like, "I'm fine. Like, I'm no different than I was yesterday." I wound up going in the next day, but you don't even know,
Right.
so it's very, very serious.
Yes.
Okay. Are there any final questions before we wrap up? I do want to say really quickly to our president, Tarina's comment that remember that, and Dr. Gilliard, you started off by speaking to this point that many of these things are silent problems. And so you don't really feel any different as a result of having many of these conditions until there is a major problem. So it's really important that we start early, taking care of ourselves, making ourselves aware of what tests we should be getting, making ourselves aware of the results, keeping track of those results, and making sure that we see the numbers trend in the right direction.
Yes, I think, yes, that is correct. And um, to that point, that was such an excellent point, Katina, that I tell all my patients, have your notebook, because Monet is my social media manager, and we actually did a little video on this because once you start having a really big care team, you might need to have all of the things written down. And so if you're able to track things and say, this worked, this didn't, that really helps your physician, especially in a short period of time, to kind of come to, get some knowledge and understand like what's going on and what might need to change or what might need to stay the same. Oh, yes. And you can also ask for a CD. That's the other thing. So if you have any imaging studies, please, no matter where it is, even if it's asked for your discs. And so every hospital, every facility, you can go to medical records or anything else, and they'll give you a physical CD, and you can put that in your folder and files. So if, let's just say like you had a mammogram at Cedars and then your insurance changed and now you're at Kaiser, and they're like, oh, you had a mammogram, but we just need the results. For anybody that needs to look at images, the results matter to us, but we want to see the pictures so we can look at that one and make sure we're not missing any very subtle changes that weren't necessarily described. So what you can always do is get that disc, and then when you come to a new place, all of our systems use the same universal language for the images. So even if your images were done in Boston, if you have a CD, it can be uploaded at UCLA, it can be uploaded at Kaiser, it can be uploaded anywhere, because the system of image of acquisition is completely universal, actually internationally.
I think we had one last question about alcohol consumption and high blood pressure.
Okay, so that's a good question. The answer is it depends. So there's like a study, I'm actually looking at the study right now because I wanted to make sure I was giving you very specific information. So ethanol there's a thing called the vagus nerve, and it can activate your sympathetic nervous system. So there was like an analysis that showed that chronic consumption of alcohol is associated with like a higher incidence of hypertension in women, and it is like at moderate consumption. And the risk of alcohol consumption on hypertension at the moderate consumption level is higher in Black people than white folks, and we don't know why. But they show like if you drink like alcohol like every day at a moderate level, that does actually result in you having higher blood pressure. And I think it's because you drink and it relaxes you, and then your body has like this immediate effect where like once the alcohol is out of the system, the nervous system kicks in, and then you have higher blood pressure. And then I'll put this like I guess I can put this little study in the chat.
There was one last question we forgot to talk about, was the food allergies.
Oh, yes. Okay, so there are some, I think it was on like the cholesterol. So it is a little bit more challenging to incorporate like the healthier fats or the less like processed stuff if you can't eat nuts. But olive oil is still usually universally accepted. And then you can still kind of try to do some substitutes, but you do have to be really careful. Like with even some of the plant-based, if you have food allergies, you have to read those labels very carefully, because you'd really undo all the healthy stuff you did if you had a really bad allergic reaction. So I always suggest just read those labels really meticulously, because the nuts, a lot of even like the protein powder like uses nuts. Mm-hmm. So if you have an allergy, you have to like, you can't just assume that it doesn't have nuts. You have to really read specifically like the fine print, because you'll see kind of a lot of them will sneak some almonds in there somewhere. Yes, a lot of plant-based foods, the way they, for like, for example, like the veggie patties that like Beyond Meat is a lot of sodium. So you might lower your cholesterol, but you might raise your blood pressure. Yes, the Impossible Burger, thank you. Yeah, you might lower your cholesterol, but your blood pressure might go up because there might be like 2,000 grams or 2,000 milligrams of sodium in that burger.
Okay, I just wanted to check one last time if there were any additional questions before we close out. I do see one comment, thoughts on mushroom coffee, Dr. Gilliard.
If you have high blood pressure, I think it technically, because the caffeine in actual coffee can increase your blood pressure a little bit. And so if it works, that's fine. I've tried it, and after 2 sips, I was like, nope, I'm just gonna, if I have high blood pressure, I'll just have to take that L, because I can't do it. But I know some folks that like it and they feel really energetic and it works for them. But so I have no negative impression other than I really don't like the taste myself.
It is an acquired taste for sure. It's an acquired taste for sure. Dr. Gilliard, first of all, I just wanted to thank you for your time, taking this time out to speak to all of us, and for everyone that's hopped onto the call. Wanted to thank you for your attendance and your participation. This was very fun and lively. And just wanted to circle back to something Katina said earlier. One of the reasons that we're doing virtual series regarding health matters is because we feel we are our sisters keepers. We want to bring information like this to the community, in spaces that's safe to talk about things that are impacting us, particularly as Black women. Um, and with everything that's going on in the United States in particular, we want to be sort of that vessel that helps to create change. So thank you again for your time. We will have the second session on Thursday, the 23rd at 7 p.m. So hope to see you back soon.